This is the Heartland Daily Podcast.
Hello, everyone, and welcome to the Heartland Daily Podcast, where this week we're going to be talking about, or today at least anyway, healthcare, which we do every couple of weeks here on the Heartland Daily Podcast. My name is AnneMarie Schieber. I'm the managing editor of Healthcare News. And joining me is Devon Herrick, who is a healthcare economist and writes for the Goodman Institute healthcare blog and writes a lot of good stuff. So we talk about a lot of the the articles that we have in both of those publications. And this week we've got a full plate. We're going to be talking about bill paying and reforming healthcare without the political fight. We're already seeing a whole bunch of fighting regarding cuts on Medicaid and a variety of health issues. We're going to be talking about FDA reform and some things that maybe might speed up the entry of some very cutting edge, very good treatments and drugs. And an issue I want to call name it to tame it, which seems to be increasingly happening increasingly because of insurance costs. I think people run to the doctor and want to get a diagnosis because they're paying so much in healthcare. But this has also a really bad effect. So we're going to be talking about that. And then the doctor-patient relationship. And patients have enough complaints about healthcare, but so do doctors. We've talked about this, but again, it all goes back to a lot of the dysfunction in healthcare planning and regulation. So we've got a lot on our plate. And to get started, I thought maybe we would talk first about this issue called consent to pay. Now, I don't know. I think just about any time I've walked into a doctor's office involving insurance, I don't see this at my DPC, my direct primary care practice, but I'm always asked to sign a form that I agree to pay whatever my insurance company does not pay. And of course, you go in there and you have no idea what you're paying, and neither do they if you were to ask, because they don't know what your insurance company is going to pay. Interestingly, New York State tried to put the kibosh on this last year and passed a law, but Governor Kathy Hochul decided to delay it because of much lobbying against this by medical providers, hospitals, and doctor practices. So there is a provision in there that seems pretty good, but again, it all leads to healthcare transparency, and we don't see this problem in any other industry except healthcare. Why are patients reluctant to pay their bills? Well, because they don't feel the bills are fair and they're surprised by the bills. Devon, you wrote about this in the healthcare blog. Why don't you talk a little bit about how you stumbled upon this and what you mentioned in your blog post?
Well, New York State passed a law that was supposed to go into effect last year. As you said, there have been some lobbying, so it's actually delayed. But what it would have done was say that you could not require patients to sign a consent to pay whatever's charged form until the doctor or the hospital had done the procedure and then discussed costs. Well, that's a little bit too late. You need to discuss costs before you do the procedure, and it needs to be discussed in a way that I can take my business elsewhere if I think the prices are too high. I mean, once the doctor or the hospital does the procedure, it's too late to walk, and there goes your bargaining power. But I think New York State and others are looking at this. They're on the right track, which is why there is no meeting of the minds. Under contract law, is required to be a meeting of the minds. It's called mutual assent. How can there be any meeting of the minds if I'm not told what it's going to cost? And when I'm being asked to sign a legal form that was written by lawyers, that they can take to court and make me pay if I don't think it's fair.
Yeah. And I think the way they left it was there is going to be a provision where they entitle or they mandate that the physician has to provide that information on costs,
Mhm.
but I don't think patients are going to get honest answers, to tell you honestly, because they simply don't know at the front desk. The price varies by patient, by insurance company, unless you're paying directly. Now, I pay a lot of times for specialty procedures directly. I don't carry traditional insurance. So I make sure I understand when I walk in the door how much my bill is going to be. But if you do that with a hospital, it's not going to happen. They'll sit down and they're going to get one of these forms in front of you, and you will not get treatment until you sign the dotted line. And, don't you think one of the reasons they want you to sign this and the reason they don't want to discuss the cost is because they know you're going to walk out?
Well, and really the right to walk out, that is where your bargaining power is. The National Center for Policy Analysis published a brief analysis 20 years ago by the very well-known health economist Elaine Enthoven. And he basically said your bargaining power, buying power, as in your large group, is not the same as bargaining power. Bargaining power is when you can say, hey, I'm not going to pay that. Goodbye. I'm leaving. I'm taking my business elsewhere. And that's really what we need if we're going to encourage or induce or require hospitals to compete on price. Is tell me what the price is before you do the work. Tell me in a way that I can easily walk if you're not competitive. And if enough patients do that, you will find that all of a sudden the hospital business office will say, wait. Now, okay, we'll do that MRI for 500 or 400 or whatever, instead of, after the fact, you had no leverage. And plus you just signed a form that said, hey, I'll pay whatever you charge. And even though we know that's wrong, even though we know that really violates contract law, at least in any meaningful way, that it still holds up in court quite often, or most often.
Yeah. And they have all the incentive to get policyholders to reach their minimum before their deductible, before that kicks in, especially at the beginning of the year. Because what happens is, let's say you have a $4,000 deductible and you get that in January. What are you going to do for the rest of the year? You're going to start maximizing your insurance and going in for every procedure under the sun so you can get that coverage. And, you're less inclined to go in for these procedures at the end of the year. That's another distortion in our healthcare system, because you can put off, and that's typically what happens, I think. People put off expensive, maybe necessary procedures at the end of the year if they are not, or if they're going to reach their deductible and not be able to maximize their insurance policy for the following year, because everything starts to zero in January. So it's
any doctor will go ahead. So doctors will tell you they are busy in December because people are rushing to spend their FSA money or their HRA money, or they've met their deductible and they want to get everything they can before that resets.
Right. And this is why health savings accounts are so critical, because you can keep that money year after year and not have to play these games. And, it would just solve so many problems. And we talked about this a couple of times, about the rules now in Ohio and Colorado, which I think are excellent. And I'm really excited to hear how things are going to go over the next year or two. But these two states have told hospitals that they cannot go after patients for not paying bills if they have not disclosed the prices in a readable format online. So that, the hospitals under Trump, right before he left office in 2021, put this order into place, and Biden just sort of dropped the ball on it. Nobody was enforcing it. Hardly anybody was complying because there was no enforcement mechanism. But now that will probably motivate these hospitals to start doing this in a very honest and earnest way.
In fact, I'm writing about that right now. That article probably, Trump's executive order on price transparency, my blog post will probably appear this weekend on that very topic. And I mean, there's a whole range of problems with the data. I mean, one of them, like there's ghost data. The ghost data is is a price for a podiatrist, for example, doing heart surgery. Well,
Yeah.
a podiatrist is not going to do heart surgery. So why are you sticking in data for, it's basically bogus, corrupted data that should be taken out that is left in. And therefore, all this bad data makes it very, very unwieldy for third parties to make decision support tools so that I can actually look up and find out what does it cost for an MRI in Dallas, for example.
Right.
It could be 403 or it could be 3,500.
And the good thing, for patients, if they can see these prices up front, they can look at their policy. And when they get their benefit statement, they can see whether their insurance company is paying more than everybody else and whether you're paying for that through higher premiums or deductibles or whatever. It's almost like buying airfares when you go in and pay for healthcare. There are fares all over the map. Same thing for health insurance. The payment system is just so inconsistent with value or, anything that reflects what the true cost of a procedure or treatment is.
You talk about travel agency. I mean, it may be that what we need is an Orbitz or an Expedia for healthcare. Okay, I need, my doctor says I need to get an MRI. Where do I get it? Well, what I do right now is I go online and I Google and I call and I check, and it's not very convenient. And I know how to do it because I've spent years studying it, but most people don't know they don't even know that prices vary.
Right.
They don't know that the hospital is the highest priced place to get it and that there may be a freestanding radiology clinic, across the street that's a mere fraction. I mean, that literally has happened to my family.
Yeah. Wow. And, we have all kinds of things that keep the prices like monopoly prices. We've got certificate of need restrictions, which reduces the amount of competition that comes into a market. We have kind of monopolies run by these huge hospital systems that are gobbling up practices right and left. And I know you've written quite a bit about, this idea of venture capital now coming in and buying up practices, and they don't care about patients really. They care. Their main goal is making money, which, there's nothing wrong with that, but they're not going to be possibly looking out for, healthcare is so personal. And
it's like what private equity and venture capital is really good at is figuring out how much they can charge. And they've realized that healthcare is the one industry where prices are opaque and you can make your customers sign a contract ahead of time to pay whatever you decide to charge. And that's especially in healthcare, that's not a good combination.
Yeah. Well, the bottom line, opaque prices are making a lot of people very wealthy off a very dysfunctional system. And as soon as we get better transparency, the better for all of us. All right, let's move on to the next topic, which is reforming healthcare without a political fight. Now, a couple of weeks ago, actually about a month ago, the Cato Institute had this phenomenal panel discussion. It was 3 hours on how we can rein in healthcare costs. They talked about Medicaid, Medicare, but inevitably, David Hyman, who is an excellent authority on healthcare pricing, he's a medical doctor and a law school professor at Georgetown, and wrote a book called Overcharged, which is excellent. Just explains how the whole system runs and why it's so costly. But he talked about this issue of avoiding the political fight in healthcare. And already we are seeing that with, the Republicans and members of Congress who are trying to get rid of some of the waste in Medicaid. And already, we're hearing screaming that patients are going to be thrown out on the street and we're not going to take care of people. And that's simply not true. There's a lot of waste in these programs, and just eliminating that waste could very much save taxpayers money. Taxpayers have a stake in this too. It's not just for patients, and patients are also taxpayers. But he talked about, this idea, which I thought was real interesting. He brought up a survey that was done a few years ago. And they asked people, they got the results of the study basically showed that more people are defensive about Social Security than Medicare. And the reason for that is because Social Security pays a check, gives you cash.
Mhm.
Here, you get the service through another person. You don't necessarily see the benefit. And, people don't value these programs when they're free or somebody else pays them, and they don't think twice about maybe wasting services or whatever. But Social Security comes in the form of a check. And anytime somebody wants to reform that, my goodness, the whole world loses its mind, right? I thought that was a really good thing. Maybe we should get Medicaid back into a cash payment system and let people spend money as they see fit. What do you think?
Oh, I just read the part of the debate that Heartland published in Healthcare News, and it just jumped out at me as so ingenious. I mean, if you give me a check, I'm going to protect that because it's valuable. If you give me a voucher for a service, nobody's happy. Just, a lot of physicians have told me, oh, Medicare underpays doctors. And so I say to them, well, why don't you drop Medicare? Just drop out, take cash, be a cash practice. Oh, no, I can't do that.
Right.
I can't make a living that way. It's like, no, you can't have it both ways. Either Medicare underpays you or, and the difference is exactly what you're talking about here. If the customer is the one holding on to the dollar, you compete for that dollar by offering better prices. By offering, a good price, other amenities, quality, you name it. But if the government is paying a flat fee, there's that incentive to say, well, that's not enough. Well, and that's the reason is because, and it became political for that reason. The government is basically saying they're setting prices. Prices were not set in a free market. There's no give and take between, patients and doctors, customers and sellers in the healthcare system. And so no one really knows what the appropriate price is because it's just arbitrarily set. But if you let seniors control more of those dollars in the form of a Medicare HSA, you would quickly find that, you would have competition as opposed to lobbying to increase fees. You would have providers saying, oh, okay, well, we'll take that, or we'll charge. And it may be a little bit more than what Medicare pays. It may be a little bit less than what Medicare pays. I mean, Medicare could still have a guideline price. They could have what's called a reference price. And if you charge more than the reference price, I may not want to see you. If you charge less, I'll be there. And so, but yeah, that's true. If it's the politics comes into play because government is the one trying to set prices.
Yeah, absolutely. And one of the things that Hyman mentioned in this conference, in this webinar, was that the average spending on a Medicare enrollee is $15,727. That's a nice chunk of change. And if you were to give that amount to everybody and let them stash it away in an account, let's say you're on Medicare at age 65. So you could be using that program for maybe a good 20, 25, 30 years. If you are a healthy person, you can stash that up, and HSAs are transferable. I mean, that's what not yet, but that's one of the things that also has to happen, that you can transfer these to heirs. It's your money, right? You've invested in this system and it's a tax. And we promised people that we wouldn't let them be without doctors or care in their senior years. But, that's kind of where it's at. The other thing they talked about too, as well, I want to make a couple of points too. Medicaid is one of the things that they're pushing for reform is Medicaid work requirements. And why do we do that? Not because they're going to make money and pay for it. It's because it allows enrollees to value the system. So if they are willing to work, it shows that Medicaid is of value to them. They're going to get a benefit if they work. And it also is good for them too, to work and collect a paycheck as well. But if they're not willing to work, then, let's say they waive Medicaid. It shows that it's not really a valuable program to them. So why are we paying this coverage?
Well, and why subsidize someone who wants to retire at age 25 or 30. I mean, there's a lot of reasons why work requirements are a good idea. I mean, you want the enrollee to value the benefits, but you want to encourage work, because if there is a way out of poverty, it generally involves work. You rarely can do nothing and get out of poverty, unless someone else is paying your bills. Well, that's what Medicaid is doing, is helping subsidize not working, and that's not good public policy, and it's not really a good way to spend taxpayer money either. So
now, in this discussion, I thought it was real interesting. They also talked about another way to avoid the political fight, and I think this could go like when you talk to employees and they don't realize that their health benefit is their compensation. It's allowing your employer to spend your money, and they have no incentive to spend any less of your money. They can go out and buy these very expensive plans because they don't pay payroll tax on that expenditure. And so, this idea of getting rid of the employer tax exemption for healthcare could go a huge amount, like take that money, and I forget what they mentioned, how much that, I think it's 18, they figured if you put this into like a universal health account for employees and their families, the employee amount, maybe you put $9,000 a year into an individual worker's account instead of providing them with health insurance. And it doesn't stop the company from providing health insurance. They are more than free to offer it. But at least it gives workers the option of whether they want to spend their money in that way. I mean, we're just saying everybody values health insurance and not letting them make decisions about what's important to them. I mean, sometimes people think joining a really nice health club provides a lot of value, but that's not going to be insurance, right? You're not going to get an insurance tax exemption for paying for a gym membership for your employees. So I think that could go a long way. And if they sell it right, I think you could get the public on board, and the opponents of healthcare cuts would really have a tough time defending that.
Yeah, it's similar to, it could be very similar to how it works in Singapore, where everyone's required to have health insurance, but, you deposit a certain amount is withheld from your paycheck, and that must go in they call it a MediSave account. Well, it's similar in the employer plans. They don't give you a choice. And if they did give you a choice, because it's your money, as we've discussed, economists virtually agree that health benefits are a form of compensation. They're just a non-cash form. And so if we had a way that individuals could control that money, they would probably be a lot more frugal with that money. And you talk about and the reason why we get it through our employer is because we get a tax deduction. Well, me as a self-employed person, I mean, I can take off certain amounts, but most people that don't have any kind of business, they can't take their health insurance off their taxes. If you work for an employer, you get it tax-free. It makes sense to equalize the tax treatment of health insurance, regardless of where you get it. And a great way to do that would be just, either have the employers pay it directly to the employee, or have the employers just pay the employee the wages they're actually worth, and then have a payroll deduction for a nominal, whatever, it could be 10%, 12, whatever it currently is now, that goes into your HSA, and then you could choose the type of health insurance you get on the same tax basis, whether you work for yourself or for a company or buy in the individual market.
Yeah, I'm a self-employed person too, and I have to shop out for my own health insurance, but there's no way I'm paying $15,000 for a health plan that I'm not going to use, really. My plan is to stay as healthy as possible, stay out of the doctor. I have an excellent direct primary care, get care through direct primary care practice. And I get my bill down, and this is providing primary coverage for my grandchildren and my daughter. I got it down to under $7,800 a year. So I I buy short-term plans, anything for resembling like a catastrophic, that would resemble catastrophic coverage, because, that could happen, and you could be faced with tens of thousands of dollars bill if you're admitted into the hospital. So you need that backup care. But yeah, no, I think it would be more equitable. We have more and more gig workers out there, and I think it's time to get rid of that and give the money directly to workers, including the self-employed. All right, let's move on. Representative Chip Roy and Senator Ted Cruz have reintroduced the RESULT Act. And it's an acronym, and I can't tell you exactly what that is. Let me pull it up here. It's reciprocity ensures streamlined use of life-saving treatments. Basically, what it allows is that if a procedure or drug or treatment is approved in a trusted country, and there's, history of that treatment, of safety, we should speed up the process for approving it in the US. And I want to pull up, if we can, Andy, this article I wrote way back in 2019. This was an amazing story, and I would encourage our listeners to just read it, because it was an incredible case. It's called "The RESULT Act Could Clear the Way for Alzheimer's Help." And we interviewed a man named David Brodsky, and his wife was diagnosed. She was 81 years old and had Alzheimer's disease. And she was part of a study that showed remarkable success. And it was in Massachusetts, but it wasn't approved for treatment. They had to do some more trials. But it was a procedure that was used successfully in Israel. And they were testing it in the US, trying to get approval in the US. And she went through it, and you have to really go down and read it. But in the bottom line was the FDA rejected this procedure. And it was really, to me, it didn't seem like it was even electronic stimulation of the brain that didn't seem like it would be, very unsafe for someone suffering from dementia. And again, they had very positive results, but at the end of the day, FDA turned it down. Now, I'd love to reach out to Mr. Brodsky and find out what happened. I did a little research, and I found out his wife has died in the last 6 years. But this is exactly what the RESULT Act is going to end if it's passed, and you've written about this like for something like sunscreens. You could go to Japan and get these phenomenal sunscreens. You can't get them in the US because you got to go through so many hoops to get them on the market.
Oh, yeah. And in fact, I bought them on eBay, and they look just like the ones you buy here. But if you read the ingredients very closely, you'll see that it's not the same ingredients. It might look like the same brand. It might look like the same bottle, but it has more advanced ingredients. And so, but it's rather expensive to get, because only a few sellers have them from Japan. Yeah. But for those who don't know about it, we have not approved in the U.S. a new sunscreen ingredient, and I don't recall the exact figure now. It's like, well over a decade, maybe closer to 20 years now. And there are much better ingredients out there. There are ingredients that feel less greasy. They don't wear off as quickly. They protect your skin from a broader, array of rays, of ultraviolet, radiation. And we can't get them in the U.S. because they're not approved here. And they're not approved here because they're not on what's called the GRAS list. That the GRAS list is generally recognized as safe. And then there are a lot of things on the GRAS list. It's over-the-counter type stuff. If it's on the GRAS list, it can be sold without a prescription. But the FDA refuses to put the much more advanced ingredients used for 20 years in Europe and Asia and Japan and elsewhere. The FDA refuses to put these ingredients on the GRAS list because they want data showing they're safe. Now, they know they're safe. They've been used for 20 years in Europe, but that's not the point. It is the process. We can't pound this square peg into a round hole. You have to go through all this range of testing so that we can file it away, or else we just don't know how to do it. Congress passed a bill, and President Obama signed it into law. What was that? 10 years ago? More than 10 years ago? It didn't help. So Congress tried to pass another law, like 6 years ago. It still hasn't helped. We could have much better sunscreens, and it's not like the FDA thinks they're dangerous. It's just we don't know how to act. You got to give us this data, and they've invited manufacturers to submit data, test studies, do clinical trials, essentially abbreviated, but it would be costly. And why would one company do abbreviated clinical trials and provide data when the second that the FDA takes the data and says, okay, we agree, everybody, all their competitors get a free ride? So
right. Who would do that? Yeah, it's kind of crazy. And this gets back to, why we need an FDA. It wasn't always the case where the FDA made drug makers prove that the drug not only was safe, but efficacious. And that is very expensive to prove over time. And it doesn't reflect real world results, right? And that's one of the nice things about this Result Act is we do have history in other countries. And as long as it has a safety history, why not bring it to the US?
Mm-hmm.
I think the only reason, who would fight against this? I can't imagine, other than perhaps maybe other drug makers who don't feel they want to bring in this competition because they already are going through such enormous hoops to get their own drugs on the market and approved. And I guess they feel like this is going to create unfair competition for them. So I'm not too hopeful. Cruz has introduced this once before and it went nowhere. I think it was back in 2021, but they're going to try again. And, we have a different Congress and a new person in the White House. So we'll see. We'll see.
Yeah. Of course, the FDA, you've mentioned, drug makers might oppose it. Well, the FDA, the bureaucracy, the deep state, well-entrenched bureaucracy, because it's always been done this way.
Mm-hmm.
It goes back to, Frances, Kelsey, and in like 1962, she famously refused to approve thalidomide because she thought the data was lacking. She was proven right. And ever since then, going back to the early 1960s, everybody at the FDA and in charge of approving drugs wants to be, the Frances Kelsey, nobody wants to be, the approvals in Europe that led to birth defects. So you have extremely risk-averse FDA that's well-entrenched bureaucracy. And I'm sure if you talk to the FDA about this issue, they're going to say, well, what about thalidomide back in 1962? Well, that doesn't mean you have to have a rubber stamp that if the second it's approved in, India, it's suddenly approved in the U.S. It could be over, in year 3 after it's approved in Britain, France, or if X number of countries in the European Union have approved this drug, within 2 years, that is assumed to be approved in the United States. You could do research on what is the safest algorithm to allow reciprocity. It doesn't have to be bring in thalidomide. So yeah. That's just a red herring.
And again, it's trusted countries. It's not going to be some third world, banana republic drug that we're going to allow. It's like, the developed nations. I think Israel is in there, and, most of the European countries. And again, it should be up to the patients and the doctors as to determine, what they want to use and whether it's going to be effective. Look at how fast we put the COVID shots on the market, right? We can do this. And that turned out probably not to be a wise decision, but, we did get them out there, and I don't know why we would stop it for anything else. So We'll see. Let's move on to the next topic, which is this idea of doctors, I'm not going to say this correctly, pathologizing mild symptoms. Now, this is something you spotted, an article in the Wall Street Journal, and I always suspected that this was going on, but this was actually kind of documented that this does take place and it's causing problems. Why don't you tell us about it?
Well, and I had the article pulled up, but I'd have to look at it closely, more carefully. I forgot the name of the author, but she's a physician in the NHS in Britain. And she had noticed over the years that increasingly, I mean, there are very serious diseases and conditions for which there are well-known pathologies, genetic cases. And some of the examples she used, let me pull it up here. Let me see, ADHD, irritable bowel syndrome, Tourette's, some that I can't even pronounce, autism, dyslexia. Anyway, there's a lot of conditions that have overlap. And they are, they're symptoms in some cases of genetic disorders. Well, over the years, what we've done is we've taken a basket of symptoms and we attribute those symptoms to a disease we cannot prove actually exists in those patients. Now, the diseases exist in more extreme patients. In other words, there's a severe form of some diseases that is very clearly documented with very well-known pathologies. And then there are more mild cases that may not even be the same disease, but share the same symptoms. And medical scientists are starting to attribute maybe a lesser form of that disease to people and labeling them with, a lifelong label as you have, whatever disease, when they really don't. They have just mild symptoms.
Yeah.
Or at least they probably don't, but they have mild symptoms. And the trouble with saddling people with a diagnosis due to some milder symptoms is then, well, for the rest of your life, you're reporting to the insurance company, okay, yeah, I actually have so-and-so.
Yeah.
And then you go online, you join support groups, and they tell you, oh, you watch out for this symptom. And so you're like hyper vigilant. Do I have that symptom? Do I have irritable bowel syndrome? Do I have attention deficit disorder? And it's like a hotbed for hypochondriacs in a way.
Well, and it can cause problems because, this idea, I'm not against name it to tame it. Okay. Sometimes people look for that clarification, but what it might encourage people to do is change their behavior. And in this article, I thought it was real interesting. They said, well, let's say you have like some sort of, I forget the condition, but the person irregular heartbeat, which is not really, that could be any causes, but that might prevent somebody maybe from not being an active person or pursuing physical activity, which can actually be good for you. And, they could probably put themselves in a situation where they increase the likelihood of fainting. And then, I was thinking too, remember the peanut allergy scare? For many years, we were diagnosing kids and telling parents that their kids could die if they go anywhere near a peanut. And we discovered this was really pretty bogus. And what it was the kids weren't being exposed to peanuts early enough and building up a tolerance to them. And we see this too a lot with allergies. You see this with gluten-free foods. My grocery store, the whole aisle of gluten-free products. And again, it's to tame a very vague set of symptoms. Autoimmune disorders don't have any pathology per se. I mean, they're defined. You can test for them and whatever, but they can't cure them. And so you could spend a ton of money trying to, all you can do is treat the symptoms. And we have a problem with over medication in this country, and that can cause problems.
And that's something I should have addressed more in the article. I didn't think about it, but that's a really good point. Is in the Wall Street Journal article, the physician had an anecdote about a young adolescent. I think she was 20. She's a young adult. And she came into her office and she had a laundry list of diagnoses going back years. And the doctor began to examine all these diagnoses, just like I say, a laundry list of them, just file, a thick file of every doctor she had seen over the last 10 years had, well, I think she has this, and then go to the next doctor. No, I think she, and they didn't rule out some conditions. They just added to them. And so at this point, it's like she was a very sick person with, half a dozen serious genetic diagnoses. And the doctor looked at it and said, I think they're all psychosomatic. The seizure she's having, the fainting she's having, it's real, but it's not the disease. It's psychosomatic. It's been told so many times that she's very sick and has so many diseases that she's convinced herself to the point that she doesn't even know she's doing, but she is actually creating a lot of these symptoms.
Right.
And it sounds, it sounds very unlikely, but I can really see how if we take a few mild symptoms, an example is a lot of autistic kids also have a bowel disorder, and no one knows why. But does that mean they automatically have irritable bowel syndrome or ulcerative colitis, or certain symptoms occur together? That does not mean you add up all the symptoms and attribute those to a genetic disorder that in its severest form is very serious, but in just a handful of mild symptoms, it's just an irritation, as opposed to, do you really have these conditions? And I guess the broader point is, it's like we're expanding the scope of what is a disease so that, in fact, we're all sick that way, officially sick. What is normal? Well, and there's a lot of things are normal that are still uncomfortable occasionally.
And of course, providers benefit from this system. And you think about insurance, and there was a time where insurance would hate to have to cover all these diagnoses, right? But there's so much vertical integration in the insurance system. They now own pharmacies. They don't own hospitals yet, but there is so much.
Some do. There's so many.
That they love the idea that they can get somebody in the primary care phase, ship them off to different specialties, sell them drugs, sell them whatever. And before you know it, they're racking up major costs. And I don't think that there is a whole bunch of stuff you can do to stave off the inevitable, right? This idea that you can cure somebody by doing all these interventions, we just don't know enough. And we have an insurance addiction in this country. Everybody wants the coverage, and the sky is the limit. And again, it's just another thing leading to the driving up healthcare prices, and people just need to be more conscious of it. All right, we are kind of wrapping up here. I want to talk about this real quickly. It was another article you wrote about the doctor-patient relationship being doomed. And we mentioned this earlier, how venture capitalists are getting into healthcare and making doctors very miserable in the process. Because again, their number one incentive is making money, not taking care of patients. And so why don't you just tell us a little bit about what you wrote here?
Well, I think it was a month ago, I wrote about how patients are not as trusting of their doctors as they once were. And doctors were kind of noticing it. Patients were going online to second guess them by, looking on Google. Of course we do. Why would we not? Well, apparently after reading, and this was also based on a Wall Street Journal article. Well, after doctors saw that article, they began to write. Wall Street Journal, the writer is saying, "Hey, wait a minute! It's not just patients. We have our issues too. We don't like the healthcare system, and for that matter, sometimes patients lie to us. Patients are not always honest with us. So, and with this, and as you pointed out, what this spells out is that the doctor. Oops, I just lost a earbud, but." The doctor-patient relationship is fractured, and I can't say it's irreparably damaged, but in your case, you have a direct primary care physician that You have the epitome of the doctor-patient relationship. But for most patients, you are relegated to maybe 10 minutes with your doctor.
Yeah.
And it's one of the complaints the doctors had was, we got to see, we work for the hospital now. We don't have any control over how we treat what we do with patients.
Yeah.
We're required to have 4 patients an hour, 8, 9 hours a day. And so how can my doctor be my advocate if my doctor works for the hospital trying to sell me a lot of services at high prices that, an independent doctor would say, no, you can wait and see on that MRI, or you don't, we may need a CT scan, but let's wait a month and see how you do on this new drug or what have you. So I think as long as the doctor works for the hospital and the hospital, wants to meet a quota, it'll be very difficult to have a real close relationship, doctor-patient relationship. And if the doctor works for the hedge fund, the venture capital, private equity, and they're told it may be impossible. And I mean, years ago, there was a local hospital chain. I think they went out of business. One of the doctors said, we were employees of this hospital. We had electronic medical records. And if we didn't do this super aggressive care, the medical record system would prompt us, why are you not ordering this test? Why are you not getting this blood work? And the doctors hated it because, they couldn't practice medicine. They were basically taking orders from an algorithm in the electronic medical records that their bosses, who ran the hospital, wanted them to do to the patients. And and you don't want that, and I don't want that, and they didn't even want that. But it's kind of the system that we found ourselves in, partly because, and I should back up, like your doctor's direct primary care. Part of the reason why physicians are having a hard time maintaining a close relationship with their patients is because, they have to see a lot of patients to pay the overhead and all the billing clerks for the 10, 15 different health insurance plans that they have to bill to, and to document all the different items they're supposed to charge for. And that was another complaint doctors had, is we have to spend so much time documenting everything so it can be billed for. Well, if the doctors were independent and just took cash, they could see far fewer patients and make more money because they wouldn't be paying billing clerks and office workers and have the office space and so forth.
And a lot of people don't realize this, but when Obamacare was being formed, the hospital industry was very successful in preventing physicians from opening up their own hospitals that they would control. And I think if that were allowed, doctors would feel a lot different about the practice of medicine. And we need to restore that. We need to, it benefits the hospital corporations to no end. They eliminate some of their competition, but the doctors are prohibited from getting into business, really. They just they're now being treated like cogs on the assembly line and just doing assembly line medicine, seeing 25, 30 patients a day, 6 minutes each. And they don't get any satisfaction out of that. It's not what they were trained to do. And, and then they've got to worry whether they're properly taking care of their patients, the fear of malpractice suits and so forth. So, it's just a really difficult system, and you can understand why doctors are frustrated, and certainly patients are frustrated.
Well, yeah, you think about it. It's like I go to my doctor, and maybe I haven't seen my doctor for a year, maybe 2. Well, the doctor really needs to pull up my file, glance at my file, read what was discussed at my previous visit, check my lab work, and I'll have new lab work with me. I always bring new lab work whenever I go to my doctor. I always have labs done on my own every year. And what I'm describing, just so the doctor can get up to speed, takes time. 5 minutes, can they really revisit everything we talked about a year ago in 5 minutes? Well, in that same 5 minutes, they could see a third of another patient. So they're being rushed, and they know, it's not, like you said, it's not enjoyable for your doctor. the doctors I know, I've talked to over the years, they enjoy treating patients. They enjoy finding out how your life is going. I mean, I recall I had a doctor years ago, Dr. Ingram. He's, passed away long ago. We ended up talking more about my job as a health economist than my condition of whatever my health was. So,
But
because he was interested in it.
right. And that's fine, because the best relationship I think you can have in the healthcare system is to have a doctor you have for a long time, who knows you, knows your likes and dislikes. Medicine is very much an art, right? And you have to know what people are willing to bear, what they want to bear. And you can't do that in the way that we've got it set up right now. There's so much turnover. There's little personalization in the healthcare process. And so it's very frustrating. We have so many things that we need to change to get back to, the days of Marcus Welby.
Well, yeah, I went to see a dermatologist a while back, and it was one my wife had seen for years, and I knew he was good, but I'd never seen him before. But I went to see him, and he was for a specific purpose. I had like a raised bump on my shoulder. Well, he looked at it, and then he said, "Well, what else do you have going on? Anything else?" And he's, for a cash payment of, I think it was like $85 or $80, I forget exactly, for the visit. He did not just the reason I went, which was I got this growth on my shoulder blade that I'm kind of worried about. And he's like, "Well, anything else?" And he looked me over. He did a skin check. He gave me a script for a steroid. It was no extra. It was, part of the same visit. Well, okay, now that we're done with that, what else do you have I should look at? Do you have any other, eczema or any? And it was just, I was paying cash. I was not using an insurance. He was not having to file insurance. I was paying. And we had a great conversation, while we're doing it. I think we ended up discussing, because there were a lot of trees you could see out of his office window. He was like, "Yeah, we don't have trees as large because they're when it's like we're having this normal conversation while he's looking my skin, my various epidermis all over for whatever I may need while I'm there." And it was, it's value added.
Yeah. Well,
there was no extra bill. It was just, "Oh, while we're here, okay, I'll do that. It's no extra charge."
Yeah. Well, again, healthcare is very personal, and it's difficult. I've had the experience once or twice where I brought up something new that I didn't call in for, and it like floors them, because they're like, "Oh, this is totally different. You're going to have to set up a new appointment." So, yeah, we have uncovered once again all the problems in healthcare. But there are some solutions, so don't give up hope. All right. Well, Devon, we've run out of time, and I want to encourage our listeners to check out healthcare news at the heartland.org website and the healthcare blog at the Goodman Institute Health blog. And we'll have links to those in our podcast notes. And if you want a free market perspective on the very latest in healthcare news, check out those sources. In the meantime, stay well, stay safe. Thank you for tuning in, and we'll be back in the next couple of weeks.